Imagine you're a professional under the age of 60, active, perhaps still years away from thinking about retirement, and you've suffered a serious proximal humeral fracture that's a break right near the shoulder joint.
A really nasty injury.
Exactly. And you've had surgery to fix it, maybe what's called open reduction internal fixation using plates and screws, or perhaps even a hemiarthroplasty, replacing just the ball part of the joint.
Standard approaches, often.
But critically, that surgery has failed. You're left with chronic, debilitating pain, maybe severe stiffness, and your shoulder just isn't working properly. It's not working the way you need it to.
A devastating situation.
So what do you do then? What are your options when those initial standard treatments haven't just not worked, but have arguably made things even more complicated?
Well, it's one of the most challenging scenarios we actually face in orthopedic surgery.
It must be.
It truly is a difficult position for both the patient and, well, for the surgeon too. Unlike the more common situations, say, treating degenerative arthritis in an older person who's perhaps less active.
Right.
These are often younger, more demanding patients. They've already endured significant trauma and then a subsequent surgical attempt that hasn't succeeded.
So they've been through a lot already.
A great deal. And their anatomy is often distorted. There's frequently significant bone loss, and the surrounding soft tissues, particularly the crucial rotator cuff and deltoid muscles, they might be quite compromised.
Okay.
So this isn't just a simple revision surgery. It's often a complex salvage procedure, and it's happening in a biological environment that's much less forgiving.
And today on the deep dive, we're going to immerse ourselves in exactly that complex scenario. We're doing a deep dive into the treatment options for patients younger than 60 who face these failed initial surgeries, either that open reduction internal fixation, which we'll call ORIF,
Maria.
or a hemiarthroplasty for these proximal humeral fractures.
And specifically, our focus today is on a procedure that's become increasingly common for difficult shoulder problems generally, but it carries quite unique considerations in this younger sort of salvage context.
Which procedure is that?
That's the reverse total shoulder arthroplasty, or RTSA.
Ah, yes, RTSA.
As you touched upon, this is where the traditional mechanics are essentially flipped. The ball part of the joint is fixed to the shoulder blade, the glenoid, and the socket part is attached to the arm bone, the humerus.
Okay.
And this design, it can leverage the deltoid muscle to provide function, effectively bypassing a damaged or deficient rotator cuff.
Which is often the problem after these failed fracture treatments.
Precisely. It's very common in this group.
Exactly. So while RTSA has, well, it's really revolutionized treatment for things like rotator cuff tear arthropathy in older populations.
Absolutely.
Applying it as a salvage procedure in younger patients after failed fracture fixation or hemiarthroplasty.
Yeah.
That's a different proposition altogether, isn't it?
It really is. It's a much higher stakes game, you could say. And the long-term results, they haven't always been clear, which is why we're focusing today on this really critical long-term study.
Published where?
It was published in the Journal of Shoulder and Elbow Surgery. And this paper specifically examines the outcomes of using the Salvage RTSA in this precise patient group under 60, failed previous surgery for a proximal humeral fracture.
And you were involved in this research, weren't you?
That's right. Yes, this research represents a significant effort to track these really challenging cases over quite an extended period.
So tell us about the patients.
Well, the study cohort, it consisted of 30 patients who met these specific criteria. Under the age of 60 at the time they had the Salvage RTSA procedure.
Okay.
Their mean age was 52, and importantly, they had a substantial mean follow-up period of 11 years. That ranged from 8 right up to 18 years.
11 years mean follow-up is significant.
It is crucial because the true durability and the potential long-term issues of any joint replacement, but especially in younger, more active patients, well, they only really become apparent over many years, don't they?
Absolutely. You need that long view.
You do. So this study aimed to provide exactly that necessary long-term perspective.
And this perspective is so vital because, as the paper's background really lays out, whilst many proximal humeral fractures can actually be managed non-operatively,
That's true for the majority.
the severe or displaced ones often need surgery. But when that ORIF fails, perhaps the screws back out, or the bony bits the rotator cuff attaches to, the tuberosities, they just don't heal.
A common failure mode.
Or when a hemiarthroplasty fails, maybe due to the socket wearing away, the glenoid erosion, or just persistent pain from those tuberosities not healing, well, you're left with a shoulder that's often far worse than if the fracture hadn't been operated on in the first place.
Sadly, yes. That can happen.
You see pain, severe stiffness, dysfunction, and often significant loss of bone or deformity. That's the reality, isn't it?
It is. It's a grim landscape. And RTSA is considered here because, frankly, the other options are even less predictable.
What sort of other options?
Well, traditional things like trying to revise the ORIF, do it again, that's often just not feasible because of the bone loss. Or if you try it, it carries equally high failure rates in this setting.
Right.
Revision hemiarthroplasty, replacing the hemi again, that's often contraindicated if there's significant glenoid wear.
Right.
Or if the rotator cuff is clearly non-functional because those tuberosities haven't healed or are gone.
So the options are really limited.
Very limited. So RTSA emerges as this potential solution. It uses the deltoid muscle as the primary motor for the shoulder, even though the underlying anatomy is highly compromised by the previous surgery and the original injury itself.
Okay.
So the key question this study really sought to answer was, what are the long-term consequences and indeed the benefits of applying RTSA in this specific, highly challenging younger group?
And the central tension, the sort of headline finding of the paper, it's quite stark, isn't it? It presents a real paradox for clinicians and patients who are considering this path.
It is, very much so. The study's primary conclusion is, well, it's unequivocal. Salvage RTSA in this younger cohort is associated with a very high complication rate.
Right.
You simply cannot look at this data and ignore that reality.
How you were up?
There is. And it's an important but. The equally important part of the conclusion, the part that offers maybe a glimmer of hope in a very difficult situation, is that despite this high rate of complications, the procedure can lead to worthwhile and durable long-term improvement in pain and function if, and it's a big if those complications could be successfully managed without having to remove the implant entirely.
Okay, let's really unpack that, because that's a statement that requires some careful thought, high risk, but potentially high reward if the implant stays in. Let's start with the reward side, the potential upside. What did the study find?
In terms of the functional improvements, the subjective improvements, for those patients where the RTSA was actually retained.
Okay, so for the 24 patients who still had their RTSA implant in place at the final follow-up, and remember, this was a mean of 11 years after the surgery.
Right, long term.
The functional gains were substantial, really quite substantial. Looking at objective measures like the constant score, which is a widely accepted functional assessment for the shoulder.
Yeah. The mean relative constant score improved dramatically. It went from a very low preoperative baseline of just 25% up to 58%.
Wow, a constant score of 25%. That suggests a shoulder that's barely functional, doesn't it? Causing significant disability.
Absolutely. It's very low.
So jumping to 58%, that's a really clinically significant improvement. It doesn't necessarily mean, I suppose, a return to a completely normal pain-free shoulder like before the injury.
No, generally not.
But it suggests a move away from severe disability towards a level that might allow for many activities of daily living, perhaps even some light work.
That's exactly right. That magnitude of improvement really indicates just how severely compromised these patients were before the RTSA.
And what about how the patients themselves felt, the subjective view?
Yes, the subjective shoulder value, the SSV. This captures the patient's own perception of their shoulder's function, usually as a percentage compared to a normal shoulder. That also saw mirroring improvement. It rose from a mean of only 20% preoperatively up to 56%.
So they felt a marked improvement in how useful their shoulder actually was to them day to day.
They did. A very significant perceived improvement.
And range of motion, that's often terribly limited after failed fracture fixation, isn't it? Especially lifting the arm up.
Yes, and significant improvements were seen here too. Active anterior elevation, so lifting the arm forward, increased from a mean of just 45 degrees preoperatively.
Very restricted.
Very. Up to 106 degrees at follow-up.
Okay, that's over the horizontal.
It is. And active abduction, lifting the arm out to the side, went from 42 degrees up to 99 degrees.
Again, functionally important gains.
Crucial gains, especially getting over that 90-degree mark for elevation and abduction. That's so important for reaching and performing many basic tasks.
And pain.
Pain scores also saw significant reductions, and perhaps surprisingly, even strength improved notably.
Really? Strength improved too?
Yes. The study highlights that all of these functional and subjective improvements were statistically highly significant. We're talking p-values less than 0.0001.
So very unlikely to be due to chance.
Extremely unlikely. Less than a 1 in 1,000 chance that these observed improvements were just random variation.
That level of statistical significance really underscores the robustness of the finding, at least for those patients with retained implants. And you mentioned the follow-up was long-term, a mean of 11 years. Did the paper comment on whether these functional gains held up over that extended period? Did they last?
Yes, and that's a really key point about the durability, isn't it? The study specifically looked at the outcomes over time, and it confirmed that the functional gains achieved at earlier time points, they were largely maintained, even beyond 10 years postoperatively, for the patients whose implants remained in place.
That's encouraging.
It is. It suggests that when salvage RTSA works in this population, it could provide a lasting improvement, which is crucial given the younger age of these patients. They need something that lasts.
Okay, so the potential upside is clear. Significant, durable functional recovery possible for a severely damaged shoulder. But now, now we must confront the other side of the coin. The side that makes this procedure such a complex clinical decision, that very high complication rate you mentioned earlier.
Yes.
What were the numbers the study reported there?
Well, this is where the challenge really lies. The study found that 18 out of the 30 patients in the cohort, that's a substantial 60%,
60%.
experienced one or more postoperative complications following their salvage RTSA.
60%. Wow. So more than half of the patients undergoing this specific procedure in the study experienced a problem afterwards. And how did these complications then translate into needing more surgery or, worst case scenario, failure of the implant itself?
Well, the rate of revision surgery was also high. The paper reported that 11 open revisions were either performed or planned to be performed in 10 of the patients.
10 out of 30.
Yes, representing 36% of the original cohort. And these revisions, they often occurred relatively late. The average time from the index salvage RTSA to the revision procedure was 71 months.
71 months. That's nearly 6 years later.
Almost 6 years on average.
So over a third of patients needed another significant operation to try and deal with issues arising from the RTSA itself. And what about the ultimate failure rate, where the implant just couldn't be salvaged and had to come out?
The study defined failure quite stringently, actually. It included explantation of the RTSA that's removing the implant entirely.
Right.
Conversion back to a hemiarthroplasty, which is a rare and often problematic step.
Mm-hmm.
Or insertion of a cement spacer. It's typically a temporary measure,
Yeah.
often used to manage deep infection.
Okay.
So by that definition, 6 patients out of the 30, that's 20% of the cohort, were classified as failures.
1 in 5.
1 in 5. This is a significant number. It represents 1 in 5 patients where the salvage RTSA just did not provide a lasting solution, and the implant ultimately had to be abandoned.
So let me just recap that. For a younger patient, under 60, with a failed fracture fixation or hemiarthroplasty, considering a salvage RTSA, they face roughly a 60% chance of some kind of complication,
Correct.
a 36% chance of needing another revision surgery down the line, possibly years later,
Yes.
and a 20% chance that the whole procedure will ultimately fail, requiring removal of the implant.
Those are the figures from this study, yes.
Those are really sobering statistics.
Oh.
They absolutely highlight the high-risk nature of this specific procedure in this specific patient group. Now, given these risks, the paper also looked at factors that might predict who is more likely to have these complications or perhaps less successful outcomes. What were the key associations they identified?
Yes, this is critical, isn't it? For informing patient selection and, indeed, surgical planning. The study found a strong association between the number of previous surgical procedures on that shoulder and the likelihood of postoperative complications.
That makes sense.
It does. Patients with more prior surgeries were significantly more likely to experience issues. The p-value was 0.005.
So, highly significant statistically.
Yes. It really underscores the cumulative damage that happens with each operation. You get scar tissue, altered anatomy, potential compromise of blood supply, the soft tissues. It just creates a much more hostile environment for further implant surgery.
Right. The more times you've been in there, the harder it gets to achieve a good result the next time. What else significantly increased the risk?
A documented history of infection prior to the salvage RTSA. That was another major predictor of complications. And this was striking. All 7 patients in the study who had a history of infection experienced postoperative complications after the RTSA.
All of them.
Every single one. The p-value there was 0.048. It's just a powerful reminder that eradicating infection, especially around orthopedic implants, is incredibly difficult, and a history of infection significantly escalates the risk of it recurring or other related complications happening with the next surgery.
So, if infection was part of the reason the initial surgery failed in the first place, carrying that history into the RTSA setting, It almost guarantees future problems based on this data.
It carries a very, very high risk, yes. The nature of the previous failed surgery also seemed to matter.
How so?
Well, salvage RTSA, performed for a failed hemiarthroplasty, was associated with a higher overall complication rate compared to salvage RTSA performed after a failed ORF.
Okay.
Specifically, 19 out of the 23 patients who had a failed hemiarthroplasty went on to have complications after their RTSA. That p-value was 0.014.
That's interesting. Why might that be?
Well, it's an interesting finding. It might suggest that the reasons why the hemiarthroplasty failed in this particular cohort, perhaps severe tuberosity resorption or significant glenoid erosion, wear on the socket side,
Right.
that these create a more complex biomechanical and soft tissue challenge for a subsequent RTSA compared to the issues you typically see after a failed ORF, like screw cutout or simple non-union.
That resonates clinically. Dealing with poor bone stock on both sides of the joint, potentially significant soft tissue deficiency after a failed hemi, that does sound much more challenging than revising a failed plate and screw construct, generally speaking.
It often is, yes.
Did the study also look at implant-specific factors? Did the type of RTSA used matter?
Yes, they did. They found an association between the use of older generation implants specifically. They mentioned the Delta Third RTSA design and a higher complication rate.
Okay.
17 out of the 20 patients who received that specific Delta implant experienced complications. The p-value was 0.018. Now, the authors rightly acknowledge the limitations of a retrospective study, and obviously surgical techniques evolve over time.
Of course.
But this finding does hint that advancements in implant design and perhaps the surgical protocols associated with newer implants might well influence the outcomes.
That's a crucial point for clinicians, isn't it? Being aware that the results reported might be influenced by the specific generation of the prosthesis used and the techniques that were contemporary at that time. The paper also noted a particularly high infection rate within the study cohort itself after the RTSA.
Yes, the overall rate of infection post-salvage RTSA was noted as 27% across the whole cohort.
27%. That seems very high compared to primary RTSA for other reasons, like arthritis.
It is high, and it further highlights the compromised state of these revision shoulders. Consistent with the other findings, factors significantly associated with this post-operative infection included, again, the number of previous surgeries and, obviously, a prior documented infection.
Right.
The study did note, however, that their management protocol for dealing with infection before performing the RTSA, typically a staged approach using antibiotic-laden cement spacers.
Yes.
That appeared effective in controlling the infection before the RTSA was put in, which aligns with other research in the field. But controlling the infection beforehand doesn't eliminate the risk of it recurring or other complications cropping up once a large foreign body, the implant, is placed back into that environment.
So even doing everything right, using staged procedures with spacers to clear a pre-existing infection, it doesn't wipe the slate clean. There's still a high risk of complications, including infection after the RTSA in these complex cases.
That's what this data suggests, yes.
Yes.
The risk remains elevated.
Okay. Beyond just complications, were there specific factors linked to inferior functional outcomes? So even if the implant remained in place, did some patients do less well functionally?
Yes. The type of prior failed surgery also seemed to impact the level of functional recovery achieved. The study found that salvage RTSA performed for a failed secondary hemiarthroplasty.
What does secondary mean here?
It means the patient had already had at least 2 previous surgeries before the RTSA was even considered. So perhaps ORIF then hemi, or hemi then revision hemi, before the RTSA.
Multiple prior surgeries.
Exactly. And in those cases, the salvage RTSA resulted in significantly inferior active abduction, lifting the arm out sideways compared to salvage RTSA for a failed ORIF.
How much inferior?
The mean abduction was just 77 degrees after failed secondary hemi versus 116 degrees after failed ORIF. That difference was statistically significant. P equals 0.023.
Okay, so multiple previous surgeries, and then specifically a failed hemiarthroplasty before the RTSA seems to result in significantly less ability to lift the arm out to the side compared to someone who maybe just had a single failed ORIF as their only prior surgery.
That's the finding, yes.
That reinforces the idea, doesn't it, that the cumulative negative effect of prior interventions really impacts the final functional result you can expect.
Absolutely. And furthermore, salvage RTSA performed after that failed secondary hemiarthroplasty also yielded significantly inferior mean active abduction compared to RTSA following a failed primary hemiarthroplasty.
So worse than just one failed hemi.
Yes. 77 degrees versus 107 degrees. P-value 0.049.
Hmm.
So again, it points to the compounding difficulty introduced by multiple previous procedures, particularly when a failed hemiarthroplasty is part of that patient's history.
And what about external rotation? The ability to turn the arm outwards. That's notoriously difficult to recover after these proximal humeral fractures, isn't it? Especially if those tuberosities, the rotator cuff attachments, don't heal properly.
Yes, and this study confirmed that observation. Even with an RTSA in place, they found significantly better active external rotation when the greater tuberosity had healed properly prior to the RTSA or was successfully incorporated into the reconstruction,
Okay.
compared to when it was resorbed, essentially dissolved away or had been resected during previous surgeries.
What was the difference?
A mean of 21 degrees of external rotation if the tuberosity was healed versus a very limited 3 degrees if it was resorbed or resected. That p-value is 0.025.
Only 3 degrees. That's very little outward rotation.
Very little. And it highlights that while RTSA is often described as bypassing the need for a functional rotator cuff for elevation,
Right.
the state of those tuberosities still plays a crucial role in trying to restore external rotation, which is often poor in these failed fracture cases, precisely because tuberosity healing is so problematic.
And did the paper link that poor tuberosity status to the failed hemi group?
Yes. It specifically notes that in 7 out of the 8 patients who had failed secondary hemiarthroplasty, the tuberosities were either resorbed or resected. And that strongly contributes to their poorer abduction rotation results compared to the other groups in the study.
That luggage is really important, isn't it? It's not just about the implant mechanics. The residual anatomy and the biological situation resulting from the previous failures significantly influence the outcome, even for a complex procedure like RTSA. Let's briefly touch on implant survival itself and maybe what they saw on imaging on the x-rays.
Sure. The study provided survival estimates using Kaplan-Meier analysis, which is a standard statistical method to estimate the probability of an event, like revision or failure, happening over time.
Okay.
They reported an overall survival rate of the RTSA without needing a revision of 69% at 10 years.
69% free of revision at 10 years.
Correct. Now, if you define survival more strictly using failure as the endpoint, remember that was explantation, conversion, or spacer insertion,
Right, the really bad outcomes.
then the survival rate was higher, 79% at 10 years.
Okay, so roughly 4 out of 5 implants were still in place at 10 years, even if some had needed revisions along the way.
That's right. Now, whilst these rates are certainly lower than often reported for primary RTSA performed for, say, degenerative conditions in older patients,
Sure.
they do provide a realistic benchmark for this specific, highly challenging salvage indication in a younger population.
That's important context. And what did the x-rays show over the long term? Any common findings?
Yes, a very common finding on the radiographic side was inferior scapular notching.
Ah, yes, notching.
This is where the metal component on the arm bone, the humeral component, can rub against the lower edge of the shoulder blade socket, the glenoid. It was present in a very high proportion, actually 92% of patients with retained implants in this study.
92%. That's almost everyone.
Almost everyone showed some degree of it. However, and this was quite a key finding, the study found that the presence or even the severity of the scapular notching was not statistically associated with inferior functional or subjective outcomes in this specific cohort over the observed period.
That's surprising, because notching is often cited as a potential concern for RTSA longevity and outcomes, isn't it?
It is often discussed, yes.
Yeah.
But in this difficult salvage setting in these younger patients, this paper suggests it wasn't the primary driver of poor results, at least not within the time frame studied.
Interesting. Anything else on the x-rays?
They also noted radiographic lucent lines around the humeral component, the part in the arm bone, in about 25% of patients.
And what did those lines mean?
Well, lucent lines can sometimes indicate loosening of the implant or stress at the bone-implant interface. And these lines were significantly associated with using that older delta the third implant model. And also with the need for subsequent revision surgery. So that further supports the idea that implant design and achieving stable fixation at the bone-implant interface really does play a role in the long-term outcome.
Right. Now, before we wrap up, it's always important, as the authors themselves noted, to consider the limitations of any study. What were the key caveats that they highlighted for this research?
Well, they pointed out quite rightly that it was a retrospective study. That means they looked back at data that was collected over time, which can introduce certain biases compared to a prospective study where you follow patients forward under a very strict protocol.
Okay.
There was also, inevitably in a long-term study like this, a percentage of patients who were lost to follow-up, about 11% in this case.
Uh-huh.
And sadly, another 11% died during the study period, which is expected given the time frame, but can affect the overall power and completeness of the analysis.
Sure.
They also acknowledged the relatively limited sample size, 30 patients in total, which meant they had limited statistical power for doing very detailed subgroup analyses. And finally, they noted that there might be inherent differences between the patient groups who initially had ORIF versus those who initially had hemiarthroplasty, perhaps related to the original injury severity or bone quality that weren't fully captured or adjusted for in the analysis.
Those are standard but important limitations to bear in mind when we interpret the findings of a study like this one. So, taking all of this information together now,
Yeah.
the significant potential for functional improvement on the one hand,
Yes.
contrasted with that very high risk of complications and failure on the other hand, particularly in the context of previous surgeries and prior infection. How does this paper really frame the overall clinical decision-making for this challenging group of younger patients?
Well, I think the paper strongly reinforces that salvage RTSA in this population is absolutely not a straightforward procedure with any guaranteed success. It is clearly associated with substantial risks.
Right.
And those risks are particularly influenced by the patient's prior surgical history and any history of infection.
Right.
However,
Again,
the buddy again. The study also presents quite compelling evidence that for those patients where the implant can be retained, it does offer a level of pain relief and functional recovery that may simply not be achievable with the other available salvage options.
if there are any other options left.
Precisely. It underscores the fact that in these severely compromised younger shoulders, all the options are difficult. None are without significant drawbacks. RTSA, despite that high complication rate, emerges as a procedure that can work.
Okay.
But it demands really careful patient selection and a preparedness, both from the surgeon and the patient, for managing the potential issues that are quite likely to arise.
It really sounds like it's often a procedure of last resort then, chosen perhaps out of necessity when other options have failed or aren't viable, accepting that high likelihood of future problems in exchange for the potential for significant, albeit maybe imperfect, improvement in a shoulder that is otherwise debilitatingly painful and dysfunctional.
I think that's a fair summary.
It forces a very difficult conversation, doesn't it, about managing expectations and accepting a significant level of risk.
Exactly. The improvements shown in the study are real, and they are meaningful for patients starting from such a low baseline with severely failed shoulders. But they come at a cost, frequently requiring further surgical intervention down the line to manage complications, and with that non-trivial chance, around 1 in 5, of ultimate failure requiring implant removal.
Well, this deep dive has certainly illuminated the complexities and the critical data surrounding salvage RTSA in this very challenging patient group. If this discussion sparked some insights for you, or perhaps clarified this difficult clinical scenario, please do consider leaving us a rating and perhaps sharing this deep dive with a colleague who might find it valuable.
Yes, we appreciate you joining us for this in-depth look at a complex problem.
And finally, a thought to perhaps mull over, drawing directly from the factors identified in this paper we've discussed.
Yeah.
Given that the study found things like a higher number of previous surgeries and prior infection were so strongly linked to complications,
Mhm.
and that factors like tuberosity healing and the specific type of failed prior surgery impacted the functional outcomes. How much of the ultimate success of salvage RTSA in these challenging younger patients is actually determined not just by the technical execution of the RTSA surgery itself,
Right.
but perhaps even more so by the surgeon's ability to meticulously select the right patients in the first place, to rigorously optimize their condition preoperatively, especially managing any hint of infection, and then possess the experience and the infrastructure to effectively anticipate and manage the almost inevitable complications when they do arise. It suggests the outcome might be less about the implant or the index procedure in isolation, and much more about the comprehensive, long-term management of a complex, previously operated, and often compromised shoulder.